I am going to start by welcoming you to this Nestle Breakfast Symposium, Goldilocks and the UnBEARable. Enteral feeding intolerance, vomiting, diarrhea are just right. Something that is a perfect breakfast conversation, right? Okay. And these are the sponsor disclosure. This is being supported by Nestle Health Science, and we thank them very much. And here are the speakers for today. So I'm going to give a little intro. My name is Beth Taylor, and I am the moderator for today. Let me introduce the speakers today. I am a research scientist at Barnes-Jewish Hospital. Was a critical care dietitian for 20 years before I moved into a research scientist role. And then we have Dr. Todd Rice with us, who is a professor of medicine with tenure in the Division of Allergy, Pulmonary, and Critical Care Medicine, and vice president for clinical trials, innovation, and operations for the Vanderbilt Institute for Clinical and Translational Research at Vanderbilt University Medical Center. I like that translational research is kind of growing now, isn't it? Implementation.
Buzzword.
It's a buzzword. Yeah, it makes them sound really cool.
I don't even actually serve in that position. I just put it on there because it's a buzzword.
Ah, that's what I figured. Okay, he currently serves as the director of the Vanderbilt University Medical Center, Medical ICU, and a bunch of other stuff. We know that he has published a lot. He does great talks, and we just love him, right? And he's here to share his knowledge. And then we have the youngest on the stage, Dr. Mundi, who graduated cum laude from the University of California, San Diego with, I didn't know that, double major in psychology and chemistry.
You know, the only way I can work with these people.
I think so. It all makes sense now how he's sometimes sitting there like this when he's looking at you. The things you find out reading a bio. Okay, he obtained a medical doctorate from the Keck School of Medicine at the University of Southern California. And he did a lot of things. And now he's at the Mayo Clinic Division of Endocrinology, working in the outpatient setting with the home patients. And he's an NIH, you're still doing the NIH thing, the training grant?
No, I finished.
Oh, he finished his NIH grant, so that's good. He should know a lot about fatty metabolism and obesity. He has a clinical, they give you these things, and you're like, are you really still doing that? Okay. His clinical focus is malnutrition as well as nutrition support in home and inpatient settings with a special interest in support of patients on enteral nutrition, which is really good for our program today. Okay, speaker disclosure. Since I'm going first, I have no disclosures. And these are our learning objectives today so that we can learn a little bit more about enteral feeding intolerance and what that means to all of us and describe kind of where we may see that across the continuum of care. And I'm going to start with this question, what is enteral feeding intolerance? So if you sit there and think about it for just a minute, because really I think it depends on who you ask a little bit, right? I bet you all might have different things coming up in your mind. But which of these would you include in your definition of enteral feeding intolerance? How many of you would include diarrhea and constipation? All right. How about bloating, distension, and abdominal pain? All right. Nausea, vomiting, reflux, gastric residual volume. So this, we picked a pretty good list, all right, that is part of showing it. But then how would you define these if you had to define them? And we'll just pick one because it's breakfast, so let's talk about diarrhea. How many would say that diarrhea means you stool 5 times in a day, 24 hours? Somebody else have a different thought? 4? 3? 2? Oh, volume. How many of you go in there and measure the stool that's in the bed? I like that. Volume. I'm like, they don't all have a butt bag on there, you know? Okay. So that's the point being is we don't always all use the same definition. And so you need to think about when these are, if they're going to be enteral feeding intolerance, how does it relate to the timing of the enteral feeding? Because there are a lot of things that can cause these symptoms, right, in our patients. So if we want to relate it to the enteral feeding, think about, well, how would you know? Is it right after they've started, within a couple days? I don't know all the answers. I'm saying these are the things we need to figure out. So there's many definitions that can be used. And so this is just one quick study that was looking at, and I gotta pull it all up. It was a large systematic review, and they looked at these 89 unique studies in ICU patients. And even when they were trying to look at enteral feeding intolerance, there were all these different definitions of these studies, so they broke them into these 3 groups. And even when they had to look at the gastric residual volume, there was 11 different definitions of high gastric residual volumes. This was before we decided they weren't that important. But regardless, what they found out, the bottom line was they found out that in these critically ill patients, enteral feeding intolerance happens a lot. Almost half of our patients who are fed have some form of enteral feeding intolerance, however you slice it. And what causes it, and what are the impacts of it? Well, there's a whole lot that may lead to it, and a whole lot of things can go wrong, right? So it could be how they're treating them, their disease state, but if we're not feeding them, it can lead to several different complications that have to do with glycemic control, or even like morbidity and mortality at times. So it's a big deal. And we got to kind of slice it and dice it and try and figure out a little bit more about it so we can lessen its existence just a bit. And these guys are going to get into the nitty-gritty. So the other thing is it just ICU patients that have enteral feeding intolerance? So once we get out of the ICU, are we ready for our honey? Just, Goldilocks, ready to sit and have our honey, right? Do you like that little no more EFI on that? Okay. Or do we still feel the sting of the enteral feeding intolerance when our patients are out of the ICU? So how many of you in here have had floor or home patients that are intolerant to their enteral feedings? Yep. So it's a great deal, right? The fun does not stop in the ICU, and sometimes our patients get started outside of the ICU. So it's becoming a challenging world, especially for some of our home care dietitians. So we know that it happens in the home enteral patient, and Dr. Mundi is going to talk about this in great depth, but this is just to show that it happens and it's out there as well. So same thing you're finding. So let's follow this case of this aging Goldilocks, having a little trouble, and so see if we can make her better.
All right, good morning. I'll try and bring some seriousness back. Actually, if you all have heard me speak, seriousness is not usually something I do well, but I'm going to talk about feeding intolerances in the hospitalized patient, mostly in the ICU. We'll deal a little bit with the hospital outside of the ICU, and then Dr. Mundi is going to talk about kind of the home enteral feeding intolerances. Here's the disclosures. I actually am a consultant for Nestle and get some money from them. That's probably not a surprise to you, but that's a disclosure. 2 other disclosures that I think are really important are I am an author on the Eden trial that I'll talk about briefly, and so you might think, he's got a little bit of a different view of that trial than I do, and that happens when you're the author of a trial. And then I'm also an author on some of the ASPEN guidelines, and so you may hear some guideline stuff and know that I'm an author on that too. The actual consultancy stuff beyond Nestle and Baxter is all non-nutritional stuff, and none of that will apply here. Here are the objectives. So we're going to define enteral feeding intolerance in critically ill patients and hospitalized patients. We're going to detail the incidence of these enteral feeding intolerances and some potential things that you can do to try and get out of the enteral feeding intolerance jail. And then we're going to, at the end, talk about a non-gastrointestinal enteral feeding intolerance, specifically hyperglycemia, and what you'll see me call metabolic resistance, and some ways that we might be able to potentially treat that. So here's Goldilocks again. 68-year-old female. Not that I'm implying Beth is 68 years old. I wouldn't do that. History of end-stage renal disease, status post-renal transplant twice, 2007, 2017. Has all of the complications that you can imagine post-transplant from 17 years. So has coronary disease, has some peripheral arterial disease, pancreatic insufficiency, probably from vascular compromise. She gets admitted to the hospital for failure to thrive, and her family reports that she has unintentional weight loss, has lost 22% of her weight over the last 3 months, and her current BMI is 16. She has poor appetite, abdominal pain anytime she tries to take anything orally. She has between 3 and 5 loose BMs. Family did not measure the volume of her bowels, so they don't technically have a definition of diarrhea, but 3 to 5 loose BMs. She's admitted, and then the nurse on the floor notices that she coughs after she takes oral intake and seems to have what appears to be some, at least, signs and symptoms of aspiration. So a formal video swallow study is actually completed, notes dysphagia, and the recommendation is a non-oral means of nutrition. You have some discussions with the patient and the family, and they say, let's do a percutaneous G-tube. We can actually supplement her nutrition at home this way. We can actually better provide nutrition for her. So it undergoes placement by interventional radiology, and she gets a G-tube. You can kind of see where this is going, probably. The following day, you've started enteral feeds. She reports severe abdominal pain, has nausea, vomiting, and in that evening of the second day, she has an episode of vomiting where she then becomes acutely tachypnic, hypoxic, and hypotensive. And this is where she gets to meet Dr. Rice. So she comes to my ICU with aspiration, and essentially this is the first enteral feeding intolerance. I guess you could go back and say, well, she came in with 3 to 5 loose bowel movements, so she already had enteral feeding intolerance, so I'll give you that one. But for me, this is like we call it a disease-changing time, or a stage-changing time in her disease, where she's had an upgrade to the ICU and is critically ill from an enteral feeding intolerance. Unfortunately, she continues to get worse. We put an endotracheal tube in her, put her on a ventilator for her hypoxemia. She starts on some low-dose norepinephrine for her shock. She develops a little bit of renal failure with some oliguria, and has multi-system organ failure in my ICU. So throughout this, we'll talk a little bit about the stages of critical illness, and this is actually taken from ASPEN and from Arthur Van Zanten, and you can see that there's a thought process now that there are different phases of illness, and critical illness and acute illness, and this first phase, which I think she's in now, she's in shock, she's on the ventilator, she's got renal failure, is called the acute phase. The one thing I will caution you is, and I hate about this slide, is that there's no chance that these are defined by days. They're defined by your physiologic state. And so day 1 to 4 is just a marker for early, really early, right? But you've all seen people who are still in shock in a week, and they're probably still in that acute phase, or, and it happens sometimes with aspiration, they get better in 24 hours and they look really good, and that acute phase is probably only a day in that patient. We'll get better at figuring out markers of what phase you're in, but don't hinge all of it on the days. So she's in this acute phase, and then if I do my job correctly, she'll get better and she'll get into kind of this post-acute ICU phase, still in my ICU but better, not quite ready for the post-ICU medical floor yet, and then the post-ICU phase, and then post-hospital discharge that Dr. Mundi will actually talk about. And I think the concept that we're starting to see now is that we should maybe potentially feed patients differently in each of these phases. So it shouldn't be a one-size-fits-all phases. So she has markers of severe malnutrition. You prioritize nutrition in her because of this. She's lost 22% of her body weight in 3 months. She has a BMI of 16. These are not great prognostic factors for her in my ICU. But on the other side of this, she's also at real high risk for further enteral feeding intolerances. She already aspirates. She already has a G-tube in place because she doesn't have normal GI motility. And now she's critically ill, which is not going to make that better. Why do we care about this? Why should we care about these enteral feeding intolerances? You could say, she's malnourished. I'm just going to give her all of the nutrition and push her through because nutrition is important in her, which it is. But enteral feeding intolerances are important also. A single one is probably not related to clinical outcomes, but when patients have multiple enteral feeding intolerances, it's been shown to be associated with independently associated with worse clinical outcomes, including higher mortality and longer ICU stays, longer time on the ventilator, all of those things. They're observational studies. I do lots of randomized trials. You can't randomize somebody to enteral feeding intolerances. You get diarrhea, you don't get diarrhea. No, you can't do that. So we're left with observational trials to try and figure this out. Beth talked about this a little bit. How do we define these? And I think there's been some movement in this area. Some of you guys may be part of Cosmogi, which is an actual Delphi process to better try and define these. But to tell you how difficult it is, Cosmogi is in this weird phase right now where they're like, we're having like bunches of disagreements because people don't agree with the definitions. And I think that's true. I think that's the phase we're in, is everybody has their own concept about what these are. I think you can think of them in three categories. First is you can think of them through, we monitor for them. So we're looking for them and we find something and we say, that's an enteral feeding intolerance. This is mostly gastric residual volumes. Secondly, I think you can do signs and symptoms. Beth talked about a lot of these. These are diarrhea, aspiration, vomiting, abdominal distension. And then third, I think you can define enteral feeding intolerance through the patient just doesn't tolerate enteral feeds, and so they end up getting 40% of what we're trying to give them instead of 100% of what we're trying to give them. And that's through what percentage of the delivery of macronutrients do they get. And we'll talk through each of these in the next few slides. So monitoring gastric residual volumes. Who does gastric residual volume monitoring at their institution? Nobody. Oh. Is there a hand raised? Nobody. I think somebody has to be lying to me. They just don't know.
How many nurses do it, whether you tell them to or not?
Oh.
There we go. Okay.
Best like you asked a bad question, Todd.
Let me help you out
Of course
there.
they don't do it. Yeah, I think there are still institutions that still do it. And I think, and I'll show you this, most of the data that we have that says you may not need to do this come from medical critically ill patients. So I get in arguments with people who are in surgical ICUs all the time, and they say, we don't really have data in our post-op surgical patients, and I think that's fair. I think there's some truth to that. So this, Beth kind of alluded to this, but I'm going to show you the actual data. So these are actually 72 studies that the authors, Annika Reintem-Bleiser and colleagues, looked at, and how did they define an enteral feeding intolerance? And you can see the number of studies. These are not numbers of patients, but these are the numbers of studies at the top that actually look at gastric residual volumes. And it ranges someplace between 20 and 4 that do this. But overall, if you add all of these numbers, it's almost 63. It turns out that it's 59 of the 63 used some gastric residual volume as a measure of enteral feeding intolerance. And what level they used obviously varies, and you can see it here. What do we know about gastric residual volumes? Well, Nutrierrhea 1, we now have Nutrierrhea 3. Nutrierrhea, the French don't like me when I say this, but Nutrierrhea is like an awful study name. I do randomized trials, we name them things, but Nutrierrhea is like nutrition and diarrhea together. And they're like, no, in French, like rhea means the study of, so Nutrierrhea is the study of nutrition. I get it, but in the US, that's like diarrhea with nutrition is what that is. And then they doubled down and they had Nutrierrhea 2, and then they were like, we're doing Nutrierrhea 3, and I think Nutrierrhea 4 is being planned right now. So they're all in on this Nutrierrhea stuff. This is Nutrierrhea 1. Nutrierrhea 1 is 450 mechanically ventilated patients, and they are in 9 French ICUs, and they randomized them to either 250 mils as a gastric residual volume cutoff or not measuring them at all. So no gastric residual volume measurements. And they said our outcome is, does measuring gastric residual volumes decrease the incidence of ventilator-associated pneumonia? So they looked at a primary outcome of ventilator-associated pneumonia. Now, if you live in my world, ventilator-associated pneumonia is already a little bit of a problem because as much as we don't have a definition for many enteral feeding intolerances, we're even further from a agreed upon definition of ventilator-associated pneumonia. But they use a reasonable objective definition, and they looked at it prospectively in this trial, and they didn't see any difference between the two arms in ventilator-associated pneumonia. P-value of 0.8 here, no difference between the two. You say, well, I don't know that I like ventilator-associated pneumonia as an outcome. They show you all of the other outcomes that you may think about, and this is small print, and I apologize, but there's no difference in any of these. So whether it's GI intolerances, whether it's that, there actually were higher number of gastric residual volumes in the gastric residual volume group. Makes sense. If you're going to measure them, turns out that you find more of them. But overall, no difference in any of the other clinical outcomes. So what is the recommendation? And this actually comes from the ASPEN guidelines that I told you I was an author on. So the recommendation is don't routinely measure these because they probably are not doing what we think we want them to do in our ICUs. And if you do measure these, and I didn't show you these data, but if you do measure these, don't hold feeds for a single isolated elevated residual volume. It turns out that most patients, 80% of patients that have an elevated residual volume, if you check it again in 2 hours, it's no longer elevated. So if you are going to stop it, make them have 2 in a row. And we do this in my ICU, we use gastric residual volumes in combination with other clinical parameters. So if the patient has regurgitation or they have abdominal distension, then we will check a residual volume. But we aren't just checking them every 6 hours just to give the nurses something to do. And then if you're going to check them, push your volumes up high. So don't stop for anything less than 300, and some of us would say 500 cc's for a gastric residual volume. And then we'll talk about this, but treatments are prokinetic agents and putting the tube post-caloric if you have an elevated gastric residual volume. All right, what about the second one, signs and symptoms? So here are the number of studies that did signs and symptoms. You can see it's 36 of the 72, so about 50% of them looked at it, and the different definitions that are listed there. Most of them did not, actually combined it with a large gastric residual volume. So what are the signs and symptoms? This is actually stolen from my feeding protocol. These are ours at Vanderbilt. These are our definitions of the gastrointestinal intolerances. Abdominal distension and cramping, defined as a tense abdomen, guarding, rebound, or rigidity on exam. Aspiration or regurgitation, that's food in your lungs or in your oropharynx or nasopharynx when somebody's doing routine oral care. Vomiting gets a great term, expulsion of gastric contents back through the oropharynx and nasopharynx. Maybe my favorite. Diarrhea, we also do not measure our volume. I don't know, did you call it a butt bed? Is that what you called it?
I probably did.
I don't even know what that is, but I'm intrigued now.
It's a fecal containment device would be more appropriate.
Got it. I wondered if it was like a cholera cot and you were just draining all of your diarrhea into a bucket. It's too
early in the morning, guys.
No, we talked about this at the beginning. It's late at night, okay. Not early in the morning. We define it as more than 3 liquid bowel movements in a day. So we do number of bowel movements also, which is hard if you have a fecal containment device because there's not usually a defined actual defecation. And then constipation, which is the absence of a bowel movement requiring specific intervention. It's usually defined by the primary team. So if we use those, what's the incidence of GI signs and symptoms and I chose the large trials here. Nutrierrhea 2 and 3 are on here. Eden, which I told you I'm an author on, and Target on here. And you can see just kind of looking at this is a busy slide. You can see looking at this that the biggest one, if you classify it as an enteral feeding intolerance, is the use of a promotility agent, but it's only reported in the Target trials. Outside of that, vomiting and diarrhea are the 2 biggest, and they're about the same incidence. About a third of the patients in trials, up to a third of the patients in trials experience this, or, depending on how it's reported, a third of the patient days that patients are receiving feedings, they will have these. So to look at these actually a little bit closer, here is just the upper GI ones. So we took diarrhea out of this. And you can see 10% of patients have abdominal distension and cramping, 10% of patients have an elevated gastric residual volume, 20 to 30 have vomiting, and then 40 to 50% of the patients in Target got promotility agents. If you look at lower GI, again, I included abdominal distension and cramping in this. Constipation's about 10%, diarrhea 20 to 30%. And then bowel ischemia doesn't happen that often, but it scares us. And it's probably a really important enteral feeding intolerance because patients that end up with bowel ischemia, mesenteric ischemia, colonic pseudoobstruction have a poor prognosis and don't do well. All right, third one, what about inadequate delivery of enteral nutrition? So macronutrients, percent of macronutrients delivered. And here again are some of the big trials. You can see in Eden, about 75% of the goal delivered, which is actually pretty good. Here is Permit, which actually got to 80%, high 70s to 80%. Again, really good. These are nutrition studies, so these do better than general practice in general. Here's Target, 1,200 versus 1,800 kilocalories a day. So in that 80 to 90% range. And you say, well, let's use indirect calorimetry. Who's using indirect calorimetry to drive things? Or maybe let me see if I can learn from Beth. Whose hospital uses indirect calorimetry to provide enteral feeds? Some of you guys raised your hands. So if you use indirect calorimetry, this is the EAT ICU trial, you get actually close to 100%, at least the EAT ICU they did. So you can see that even when we're using indirect calorimetry or we're pushing these trials in nutrition centers that do nutrition well, we still struggle to get to 100% of our goals. And the biggest reason for that is because feeds get held for enteral feeding intolerance. Unless you're in my ICU, in which case it's transesophageal echoes, which feeds get held for like 24 hours for. It like drives me nuts. But no, I'm kidding. It's still enteral feeding intolerances even in my ICU. All right, so those are sort of the GI ones, but what about extra GI enteral feeding intolerances? And I think there's a couple here that are really important. Lots of people don't like this study, and it doesn't matter if you like this study. I think we can use it to point out an extra gastrointestinal feeding intolerance, and that is what I call metabolic resistance. This trial was done by Doig and colleagues, and it's about refeeding syndrome, and they took patients that got hypophosphatemic on day 3, and they randomized them to continuing full feeds or backing off and giving them trophic feeds until their hypophosphatemia essentially resolved. And you can see here in the full feeding group, the top right is highest daily blood glucose. So you can see patients that get fully fed actually had higher daily blood glucoses than patients who actually had trophic feeds. We know this from a couple other studies. If you feed patients less, they tend to have less hyperglycemia. The bottom panel, though, I think is fascinating. This bottom panel is highest daily arterial lactate. So in patients that were being fully fed, they actually had elevated lactate levels. At the time this was published, I had a guy in my division who was a metabolomics guy, and I said, Josh, what do you think is going on here? Like, what's happening here? And I said, do you think by feeding these patients, they're getting gut ischemia and we're seeing lactates? And he said, yeah, I don't think that's really it. He said, what I think is happening is that the body is not able to use the glucose, and we actually convert the glucose into pyruvate and then into lactate, and we're starting to see this lactate is a sign of a feeding intolerance, that we have hyperglycemia with it, the body can't use it, and therefore we convert it into things that we can get rid of and get out of the body. And so I and others have started labeling this as metabolic resistance. You've maybe heard of anabolic resistance, where we can't use protein that we're giving patients early in their critically ill course. And I think you see the same things with carbohydrates. And I think it's an important enteral feeding intolerance that we should keep an eye on. So let's go back to our case. So day after ICU admission, she's a little bit better. She's down to 50% on her oxygen, and her shock's improving. She's still on a little bit of norepinephrine, but her shock's improving. So you say, I'm gonna restart these enteral feedings per her G-tube. You're nervous, you're anxious. She just had an aspiration event, but she's malnourished and she needs nourishment. So you say, I'm gonna start some standard enteral feedings at 25 mils an hour, and her goal is 70 mils an hour. What puts her at high risk for enteral feeding intolerances? One is she's already shown you that she has some. Second, she is pretty critically ill. She's still in shock, although better. So she could be having some mesenteric ischemia. She's actually not going to get proned in my ICU right now, but if she were, that would also increase her risk of enteral feeding intolerances. One of the things that I think is important is to understand the risks in these patients. And here's Nutrarea 2. Neutropenia 2, remember, is patients that were in shock and they got randomized on mechanical ventilation in shock. They got randomized to enteral nutrition versus parenteral nutrition. And I think it gives us a pretty good view of what the enteral feeding intolerances from enteral nutrition in patients in shock might look like. This is a big study, 2,400 patients. Again, most of the shock here was sepsis, which probably is our patient, and almost all these patients are medical. No differences in outcomes, which isn't why I actually put this in here. Here is your enteral feeding intolerances. And you can see from this, vomiting occurs in 34% of the patients enterally fed. Interestingly, vomiting occurred in a quarter of the patients that were getting parenteral nutrition. So we weren't even giving them excess stuff in their stomach, and they were still, or in their GI tract, and they were still having vomiting. Similarly, diarrhea occurred in 36% of the patients in the enteral feeding and a third of the patients in the parenteral feeding. And then the bottom two are the ones that scare people, and that is bowel ischemia or bowel mesenteric ischemia and this acute colonic pseudoobstruction. And they're almost twice as high when we enterally feed these patients. They're still low in both groups, 2%, 1% in the two groups, but they're twice as high in the group that's enterally fed. The caveat here is, and Jay Patel's been on this campaign for a while, these patients were fully enteral fed, so they were pushed to trying to get to full feeds. And Jay always says, well, what would we see if we gave, as I showed you in the phase of the illness, 25% or 50% of what we think are the goal targets during this shock phase, because this is the acute phase. And I don't think we know the answer to that, but I think that's coming. I think we'll find that out soon. Other things that cause enteral feeding intolerances in critically ill patients, medications that we use. So both the catecholamines that we're using for pressors, for blood pressure, opioids, sedatives, all decrease GI motility. The enteral feeding formula probably is not the key contributor, but it probably plays a role in some cases. High fat, high osmolality formulas are more likely to give you enteral feeding intolerances. We saw that with Target. Target was, the intervention was 1.5 kilocalories versus 1 kilocalories, and the 1.5 kilocalorie had more enteral feeding intolerances, even though they got the same volume because of the higher osmolality. Specifically for diarrhea, now when you talk about medications, you talk about laxatives. You guys should look, and you probably will, and will laugh when I say this, but you'll see a high percentage of your patients that have diarrhea that are getting laxatives by the primary team, right? I do this on rounds all the time. This patient's having lots of diarrhea. Oh, well, maybe we should stop their sorbitol, their Go Lightly, right? All of those things. Oh, well, they were constipated a week and a half ago. Well, they're having diarrhea right now, so they probably don't need those things. It's probably the biggest reason that patients actually have diarrhea. And then again, some of the formulas may actually lead to some of the diarrhea with high fat, high osmolality formulas. We'll talk about this in the next few slides. And I added this specifically for our patient. Remember, our patient had pancreatic insufficiency from mesenteric ischemia, or from pancreatic ischemia. And so sometimes comorbidities like pancreatic insufficiency they didn't go away when she came to my ICU, so that may also be contributing to her diarrhea. What enteral feeding intolerances should you expect in the different phases? They all can happen in pretty much any of the phases. But if you look in the early phases, you usually see mostly upper stuff, elevated residual volumes, gastroparesis, vomiting, regurgitation, aspiration. The metabolic resistance actually occurs early. And then the mesenteric ischemia, which is not an upper part. And then you'll see maybe a little bit of constipation, diarrhea, abdominal distension, but that tends to be a little bit later in their course. This concept of maybe we should do something different during that early phase has some data behind it. These are the best data. These are data from Arthur Van Zanten and his group looking at an observational study. Actually, it's a retrospective look at a randomized trial, but they didn't randomize to this, so it turns out being observational data. Looking at protein delivery. And that top green line is low protein, less than 0.8 grams per kilo per day for the first 3 days, and then higher protein after the first 3 days. The middle is higher protein the whole ICU stay, and the lower is lower protein the whole ICU stay. But you can see this sort of dynamic component is actually what ends up with the best outcomes. And because of that, I think one of the potential treatments for enteral feeding intolerances during the acute phase, so during the first few days when this patient's really, really sick, is decreasing the enteral feeding rate. And you can go back. At my institution, we do trophic feeds, so we do 10 to 20 cc's an hour during that phase. But I think if you're pushing goal feeds and the patient's having enteral feeding intolerances during that early acute phase, I think you're okay to back off. And I think we have some data. I showed you some of that first observational data, but I think we have some data that suggests that. And then this is new this year, Diarrhea 3, which actually sort of studies this idea a little bit. They took 3,000 adults. You had to be on the vent and pressors, and you had to be starting enteral nutrition within 24 hours of being on the vent and pressors. And then they randomized you to what they called the low group, low calorie and protein targets, 6 kilocalories per kilo per day, and 0.2 grams per kilo per day of protein, or standard group, which was 25 kilocalories per kilo per day and 1 to 1.3 grams per kilo per day of protein, and they continued that for 7 days. And they had two primary outcomes, 90-day mortality and when were you ready to get out of the ICU. Here's what they did. Top left is the actual prescribed nutrition. Top right is the actual calories per kilo per day delivered, so that would include glucose infusions and propofol, et cetera. And the bottom is protein. And you can see if you look at just kind of calories, the standard group got about 25 kilocalories per day. Their intervention group got about 10 kilocalories per day total. Protein, it got between about 1 gram in the standard group and 0.2, 0.3 in the intervention group. Here's their actual time to ICU discharge readiness, and it actually favors the lower group. There's no difference in 90-day mortality. Here are the actual numbers, if you like the percentages. So 90-day mortality, 41.3% in the lower group versus 42.8% in the higher group. Time to ICU readiness discharge was 8 days in the lower group versus 9 days in the full-fed group. Suggesting, again, that maybe less feeds in that early part is actually better for our patients. This is, I think, a mild improvement, 1 day of time for ICU readiness discharge. And if you actually read, I wrote an editorial on this, where I think there's some potential biases in their ICU readiness for discharge. But I think this gives us more than enough data, especially with Eden and Target and a bunch of the others that are out there, to say in that early phase, you can get away with feeding patients less. So if you're running into enteral feeding intolerances during that phase, I think it's fine to back off. Not back off for the patient's whole hospital stay, but during that acute phase. And many of you may have heard me say this before, but how does this happen in my ICU? We intubate patients, start them on pressors, and then within 24 hours start feeds at 10 or 20 cc's an hour. And then I don't pay attention to it for a few days. And almost invariably what will happen is the nurse will come to me and say, hey, Dr. Rice, I know that this patient's on feeds. Do you care if I increase the feeding rate? Usually it's day 3, day 4, something like that. This, I think, is a crude way of me knowing this patient has moved out of the acute phase into this post-acute phase. The nurse is no longer drowning, trying to keep his or her head above water and trying to just put out fire after fire after fire. They've actually had an opportunity to survey their whole patient in the scene, and they go, oh, we're feeding this patient. I can increase their feeding rates. I don't think it's going to be the best biomarker, but I think it works pretty well, and it suggests that the patient's probably out of this acute phase, and you're ready to push those feeds higher and see if the patient will tolerate even more. In the post-acute ICU phase, so after the nurses come and said, can we increase the feeding rates, you'll see more lower GI enteral feeding intolerances. So this is when you start saying, the nurse says, this patient hasn't had a bowel movement since they've been in our ICU. And you go, oh, well, maybe we should do something about that. Or the patient's having diarrhea. You still see a little bit of the upper GI ones. They're a medium-sized font in this slide. And then abdominal distension and mesenteric ischemia is less frequent in this stage. All right, so we start feeds. We advance to 50 mils an hour. She has abdominal distension and pain. She has what appears to be enteral feeds in her posterior oropharynx. So she has some regurgitation. How are we going to treat this? If she's in the early phase, she's still in shock, this is day 1 or 2, I'm going to back off. She's not going to get 50 mils an hour. She's going to get 10 to 20 mils an hour from me. If we're in day 4, day 5, she's stabilized, she's not on pressors, maybe even off the ventilator at this point, I'm going to do things like prokinetics. I'm going to move the tube to a post-pyloric position. Now, she has a G tube, so that's not quite as easy as it would be otherwise, but we can still do it. I'm going to look at her medications and say, what are the potential offending medications here? Stop her narcotics. And we'll talk about this in a few slides. I'm going to assess her enteral feeding formula. If she was having diarrhea, these are the things I'd think about. Stop laxatives, we talked about that. Maybe use opioids, add some fiber. It drives my nurses actually crazy, but then they realize that it works. They'll say, this patient's having lots of diarrhea, what should we do? And I'll say, let's add fiber, and they go, ooh, won't that make them have more diarrhea? And it turns out that oftentimes in our ICU at least, patients have diarrhea because they just are not able to bulk their stools, and that fiber will actually allow them to bulk up their stools and their diarrhea gets better. If it doesn't get better within 2 or 3 days, stop the fiber. It's not working. That's not the answer. Just get rid of it. And it works a fair amount of the time. The nurses, it's always funny. They'll come and they'll say, man, I thought that fiber was kind of hogwash. I wasn't convinced that was going to work, but the diarrhea is better. Now, it could be, you could say, well, their diarrhea just got better and the fiber was completely irrelevant and all of that. But I think the fiber does do something. And then you can consider using a different enteral feeding formula that we'll talk about here. So what do we know about enteral feeding formulas and intolerances? A couple of studies. One is the DIVINE study. I should have put this as a conflict because I actually was part of the authorship and the steering committee of this study. This was dietary management of glucose variability in the ICU. The intervention was a high-protein formula. The control group was a high-protein formula. The intervention was a very high-protein, low-carb formula to try and decrease glucose intolerance. And here you can actually see the two formulas and concentrations of stuff in them. And the goal was to try and give 1.5 grams per kilo a day of protein. And I won't go through all of the results, but the summary is that this very high hydrolyzed whey-based protein with low carbohydrates actually resulted in better glucose control. So we had less incidence of hyperglycemia, more blood sugars that were in the normal range, and decreased insulin use, and potentially lower mortality. We also had fewer GI intolerances actually in the very high protein group. And you see a little bit of that in mass in the next two studies and slides that I'll show you. This is actually looking at almost 13,000 patients from the Premier database. What formula did they get? WPBD is whey-based protein, a whey protein-based diet. OPBD is an other protein-based diet. And then SETF is standard enteral tube feeds. And you can see GI intolerances. We're looking at glucose intolerance here, but look at the first column first. GI intolerances are lower, 13 versus 15 versus 18% in the whey protein-based diet. Glucose intolerance also lower in the whey protein. And then mortality is a little bit of a dirty signal here. But so decreased both GI intolerances and extra GI intolerances in this. Say, well, that's one study. Here's a second study, almost 20,000 patients. This is in 67 hospitals, looking at the same thing, and you can see the definitions on the right. Enteral feeding intolerance was defined as any of abdominal pain, abdominal distension, constipation, diarrhea, nausea, or vomiting. And hyperglycemia was an abnormal blood glucose. And you could see again, the reference here is the 100% hydrolyzed whey-based protein. And the odds ratio, if you were getting an other peptide-based, is 1.18, being an 18% increase in GI intolerances and an 81% increase in hyperglycemia. Even the standard intact protein, there was 15% increase in GI intolerances, not as big of a difference in the hyperglycemia. So the formula can make a difference for both hyperglycemia, which I think people kind of intuitively know, but it also can make a difference for GI intolerances. And in general, the 100% whey-based protein formulas tend to have fewer enteral feeding intolerances. So here are the actual numbers for those. If you don't like odds ratios and you actually want to see the percentages, here they are by the colors. So what did we do with this patient? First 3 days in the ICU, she had abdominal distension. We already talked about her regurgitation. She's finally off pressors on day 3. Day 4, we put a J extension through her G-tube and then put an NG in for gastric decompression. She continued to still have some abdominal distension and vomiting despite those measures. On day 6, we said, why don't we change her and give her this enzymatically hydrolyzed 100% whey peptide-based formula, and she actually tolerated it very well. She didn't have any enteral feeding intolerances after that. She continued to improve. She went to the floor on this whey-based protein and did well on the floor with very few enteral feeding intolerances. And then she went to go home through rehab. And on discharge, they told us the rehab facility won't give her this whey-based protein, of course, because they don't like the cost, and they're going to convert her back. So they converted her back to a non-whey-based protein. So enteral feeding intolerances are common, heterogeneously defined. What occurs as an enteral feeding intolerance probably depends on what phase of your illness you're in. In the acute phase, one of the potential treatments is reducing the enteral feeding rates, but that's, I think, is only applicable in the acute phase. If you're at a patient who's stable and a week in or 2 weeks into their illness, I don't think trying to reduce their rates is what we should try to be doing for treating enteral feeding intolerances. Later in the illness, I'd use other things, post-caloric feeding, promotility agents, et cetera. And then, if you've exhausted what you think are all your options, consider whey-based peptide formulas because they actually have been shown to reduce enteral feeding intolerances. All right.
Okay,
Now she's home.
finally.
Finally. Yeah.
Thanks so much. So I'll take over now for the home side. In full disclosure, some of the work I'll present is funded by Nestle, graciously allowed us to do this. But all of that money, including speaker fees, goes to my institution. I think I should have gotten a business degree instead of that psychology degree. So I'll mainly shift focus to the home population. And going back to our case, just like we had discussed, Goldilocks, thanks to all that translational knowledge at Dr. Rice's institution, was better. She recovered and then during the hospital continued on that 100% whey-based formula. And then prior to discharge, and this happens quite frequently with us, many insurances require at least sometimes a trial of standard polymeric formulas before they will cover this. So she was transitioned back to that formula and then came back for a return visit, and at that point reported that despite us setting a goal for about 4 containers per day, she was only able to tolerate 2 and barely tolerate that. She had bloating, gas, abdominal pain, and diarrhea. So the real question is, what do we do next with this? And I'll just start with, overview of all of the formulas that are on the market for us. Standard polymeric formulas, when we refer to those are ones with intact protein, complex carbohydrates, and typically long-chain triglycerides. We have a huge growth in the number of products available in the next category, blenderized tube feeding, both commercially available, and then more and more patients are also asking for recipes, et cetera, to do this at home. Many of them say that I want to eat what my family's eating and I want to blend that. We also have peptide-based formulas, which I'll largely talk about today. Here, the peptides have been enzymatically hydrolyzed and broken down into smaller amino acid chains. The lipids often are provided with a significantly higher medium chain triglyceride content. And then we have elemental formulas. And here, individual amino acids, much less fat, designed for to improve tolerance. When we look at the guidelines, really, we have a lot of guidelines and a lot of data for the inpatient side, especially critical care, but I think the home side is quite lacking. ASPEN does have home enteral nutrition guidelines, and they do recommend starting with standard polymeric formula for those patients as well. And then they have recommendations regarding fiber and then fiber-containing formulas. We can also sometimes rely on the inpatient guidelines, and you can see the same thing there. Enteral nutrition ICU start with standard polymeric formulas. Same thing with ASPEN guidelines. And these are the indications that are listed. Typically, we want to start enteral nutrition in patients who are at high risk for malnutrition complications. They're unable to meet their nutritional needs orally, and they have an intact GI tract. So the gut is working, we like to use it. Contraindications, obviously you could see if the gut's not working, then we're not able to use enteral nutrition. And we looked at this, started early on as we were kind of establishing our program just to get a lay of the land. So we pulled data and partnered with a couple of DME providers, pulled Medicare data, and showed that the home enteral nutrition population in the U.S. had increased significantly. So Dr. Lynn Howard, who did this study in the 90s, estimated about 152,000 Americans on enteral nutrition at home. We saw this had grown to well over 400,000 by 2013, and it continues to grow. I think if we repeat it, we may be getting close to 500,000 folks. So there's a lot of folks on enteral nutrition at home, right? But what about enteral nutrition intolerance? I don't have to go through these slides because Dr. Rice did such a great job of showing how prevalent enteral nutrition is in the hospital setting. I'll just reiterate that with some of these studies that looked at this. So in the ICU population, typically we're looking at over 30% of patients having some component of intolerance, as you can see that there. Those are the typical symptoms. He's gone over this quite a bit. Other studies have also looked at non-ICU population, and you can see in this study they looked at both ICU and non-ICU. ICU, again, 36% of patients, so very common. Non-ICU, 26%. So things get a little better, but you can still see enteral feeding intolerance is quite prevalent. But then what about the home population? And we really had no data. So this is where we looked at our own cohort. This took us years to do, and it was meticulous chart review by, I think, countless research fellows we had over a span of 3 to 5 years. And we collected 1,600 patients that had initiated home enteral nutrition at our institution. You could see the baseline data there, but the next graph was what was so eye-opening for us. We tried to look at complications with home enteral nutrition, and more than half of those patients had some complication with home enteral nutrition. And they were broken down into tube-related, enteral feeding intolerance, and then some sort of lab or metabolic change. And you can see almost 20%. So, right, it goes down from 30, 26 in the hospital, down to 20% of patients are having enteral feeding intolerance in the home setting. So even though they're a lot better, it doesn't go away. That's 1 in 5 people. And then here's the breakdown of those complications. Tube-related, most common was granulation tissue, but infections and other things are still happening. But here are the symptoms for enteral feeding intolerance that were reported. You could see nausea, vomiting, diarrhea, constipation. All those same symptoms are still present. So we're going to have to know how to manage this if 1 in 5 of our patients are experiencing these symptoms, right? With our patient, again, she started on standard polymeric formula, and she's only able to get to about half of where we need to go. And this is how she describes it. I feel bloated after my feedings, and then I have abdominal pain that feels like an ice pick moving around. And then there's diarrhea as well, right? So just kind of as a show of hand, just more get us awake. What would we do next? Dr. Rice talked about fiber, so how many would change her to a formula that contains some fiber? By a raise of hand, okay. Thank you.
I said it, I got to stick with it, right?
Yeah, you did. What about adding pancreatic enzymes? We mentioned she has that history of pancreatic, yep, okay. Change her to a peptide-based formula? Some would, yeah. Change her to continuous feeds, so try to alter how we're providing the feeds, great. Or change her to TPN. Good, okay. So that's what we did, all of the above. We started with fiber, just like Dr. Rice had mentioned. We changed her to fiber-containing formula. Then we even provided those formula slower. Then we switched to continuous feeds, right? But she kept having symptoms. And now she was calling us back and saying, what do we do next? What do we do next? She even went to the ER, and they did a CT scan. It was unrevealing. They did a GI consult, and GI said, well, diarrhea, so loperamide will take care of it. Thank you for this interesting consult. So what do we do now? Do we now go back to adding pancreatic enzymes? Anyone else? Change her to a peptide-based formula, blenderize feeds, refer her back to surgery, say you operated, it's your problem, right? Dr. Martindale's right there. Yeah, oh, applause. Try a different gastroenterologist or TPN, right? So I'll kind of talk about what we sort of discovered almost through this case and some of the work about peptide-based formulas as one option in this situation. And here I drew some of these, had insomnia, I guess, at one night. But what I'm trying to show you there is that it takes a lot for us to actually, it's like a miracle almost, like how do we absorb what we eat? But the steps in terms of us absorbing nutrition are that the first step, there's denaturation. Then the proteases kick in and start breaking down our protein into smaller and smaller amino acid chains, and then they get absorbed after that. And there are certain transporters like this PEPT1 that can absorb di and tripeptides, right? So these channels, especially in my other world of intestinal failure, we see that when patients have short bowel, these channels are increased in the colon. So we can use these channels to get more absorption of our protein. Same thing with lipids. What's happening when the lipid end is that we consume, first the bile salts have to emulsify that big lipid droplet, then the lipases can act on that, break it down so that it can finally be absorbed. Once it's absorbed, then it has to be put into a chylomicron and then pass through our lymphatics, where it's released in the thoracic duct and then goes all over the blood. Medium chain triglycerides, on the other hand, can kind of get right through, go into the portal circulation and get to the liver. It doesn't stop there, because when they get to the liver, the long chain triglycerides, they have to go through this carnitine transport to get into the mitochondria, whereas the medium chain triglyceride, they can go right in, right? So there is that advantage of using more medium chain triglycerides to get oxidation and use that for energy much faster. The clinical data, again, is sparse, but there's a lot of work that's been done in the home population in different groups. So the first one is abdominal surgery, and you could see here 19 participants after major abdominal surgery were randomized to a peptide-based formula or parenteral nutrition. And you could see that with peptide-based formula, you were able to reach goal in most of these patients and avoid parenteral nutrition. And so there was a huge cost savings compared to parenteral nutrition in this study. There's a lot of work done in terms of pancreatitis as well. So here, over 30 patients, approaches, again, comparing peptide-based formulas to parenteral nutrition, and you can see that they were able to reach goal. And again, major difference was in the cost compared to parenteral nutrition. Another study with pancreatitis kind of showing the same thing, right? You're able to reach goal, but in this situation, you could see length of hospital stay comparing peptide-based formula to standard polymeric formula was much shorter, and the weight loss was much less. HIV, and this is in the era where there was a lot of malnutrition related to HIV. Again, this study randomized the standard formula to peptide-based formula, showing you under weight change that the standard polymeric formula lost weight, that group, but the peptide-based formula group actually gained weight. And thus their skin fold was also different. And then the hospitalization is really where you see the difference. You could see much, much higher hospitalization rate in that standard polymeric formula group. right? So there's a lot of data to kind of support this, and this encouraged us to then look at our own data and see what are we seeing in the current home enteral nutrition population. So we set forth to look at all of our patients that had been placed on peptide-based formulas in those years. We found 95 of them. Again, before a lot of this work, we were not using these formulas as much. We found 53 patients were directly started on the peptide-based formula, and 42 had to be switched from a standard formula to this, to a peptide-based formula. You can see the reasons there. The ones that were directly started had kind of a component of malabsorption. So we felt like they really needed this to begin with. Others, we switched mainly for intolerance-related symptoms. And these are the formulas that we found. We were using quite a spectrum. But I think this slide opened our eyes the first time we looked at it. We focused on patients who had been switched from a standard polymeric formula to a peptide-based formula due to intolerance. And we found that after the switch, the symptoms were reduced by almost half, almost 50%. So you could see here nausea and vomiting going down, diarrhea going down significantly, abdominal pain, cramping, et cetera, going down significantly. And then after the transition, almost half of the patients had no symptoms whatsoever. So really dramatic results. But this also shocked us just as equally, which was healthcare utilization. I think we forget all of that in terms of when we're focused on just that one particular patient and trying to get them to feel better. We forget that if patients don't feel better, they call us back, they come in for visits, they actually go to the ER. And just that one visit to the ER and a workup can be thousands and thousands of dollars, as I'll show you. And that's what we tried to look at. You know, are there studies looking at how much does it cost for someone to visit the ER and have a symptom of constipation? It's almost $2,300 in 2011. So now you could imagine how much that would be. Another study looked at, well, what if they get hospitalized? It was over $5,000 in some cases, you know. So when you get into that acute care, things are quite expensive. Other studies that we saw came out about the same time and actually validated some of the findings we had. I called it real world, even though Mayo does exist in the real world, but this is data from other medical claims. So much broader swath of the US. Again, very similar findings, right? You could see that after transitioning from a standard polymeric formula to a peptide-based formula, the symptoms start to go down significantly. You could see diarrhea, nausea, vomiting, distension, gastric residual, and constipation. And they also looked at, so this is number of episodes, and they also looked at that same healthcare utilization. And again, validated what we found, right? As symptoms improve, the cost of care improves significantly. So then we started to look at, well, could we actually capture the healthcare utilization component? And we designed this study to look once again at our cohort of patients who had been transitioned from a standard polymeric formula to a peptide-based formula and pull all of their financial data. What was the cost of each test that they incurred as they were going through this transition? This took us another 2 years of meticulous review of charts, and then we even had to go through line by line each charge and then assess if that was appropriate to associate with home enteral nutrition related charges or non-enteral nutrition related charges. So here's some of the baseline data. You could see that there. But this is the real data that we saw, and again, was just eye-opening. It once again, so this was a bit different cohort than the one we did the first time, and it again showed that the EFI symptoms were decreased by almost half after this transition. But the next slide, we had to re-verify like 3 or 4 times with our statisticians and say, you know, is this accurate? Because what we saw was, in terms of health, home enteral nutrition related costs per patient per week, and this is in dollars here, you could see how enormous the cost is that as they were coming in for that workup for their feeding intolerance symptoms, the cost started to rise significantly. And this is, averaged and medianed, because some patients incurred significant costs because they had to have a huge workup in the hospital. But here you could see the cost going up. And then when you make that transition, the cost starts to kind of go down for all of these factors, right? So not only are they experiencing improvement in symptoms, but, we're saving healthcare quite a bit. And this was then all costs. And most of this cost was related to home enteral nutrition. So they were getting admitted for workup for diarrhea, needing EGD, et cetera, and then the charges just started piling up from there. So with that, I appreciate Dr. Rice giving me the time he did. I'll summarize and just say, the prevalence of home enteral nutrition has increased significantly. So we're close to, I feel, 500,000 Americans on home enteral nutrition. And unfortunately, they're experiencing a lot of symptoms at home. So we need to follow these patients closely, especially for enteral feeding intolerance, because that's translating to not only healthcare costs, but it's translating to us not giving them adequate nutrition. And one option for these patients, I think, that we have switched to is the peptide-based formulas, and you can see the results there. And we've done the similar approach in the pediatric patients. I didn't go into that in detail, but very, very similar results that you could see there. And then this is, in essence, there's always this talk about how expensive these formulas are, but they're not as expensive as even a small workup for these symptoms. So back to our patient, just to kind of close it out. We did transition her finally, after going through every formula available, to 100% hydrolyzed whey protein peptide-based formula, and she was able to tolerate that better. She then sent us this message. We're always nervous opening up InBasket, but in this case it was quite good, and said, symptoms of pain, bloating, gassiness, general feeding difficulties have all but resolved. Starting to feel stronger, have more energy, and doing my ADLs now without much effort. I really feel that all the changes that have been made have definitely shown great benefit, and I'm so happy. So thank you for that.
About a third of the patients that we care for on enteral nutrition are going to experience this feeding intolerance at some point. And it can be any time in the continuum. It's not just the ICU patients, but it's also our floor and home patients. And the number, as we just heard, of home patients is going up. So there's a lot of work there beyond the walls of the hospital, right? And we don't fix them, and it costs the hospital more. And I think this is a huge thing for all of us. We really got to thank you for doing that nice, beautiful chart. I hope everyone got a picture, because when you have to go back to your institution and make a case for some of the formulas that may cost a bit more, you say, but look what I'm going to save you, and these patients not coming back in, right, for workups and stuff. So we see that the use of these peptide-based formulas decrease the incidence of the enteral feeding intolerance, which definitely is making Goldilocks happy. So she's having a little honey peptide shake for lunch later, so really happy about that. I'm going to see if there are any questions. If you have some questions, I see one. Yeah.
I actually have 2 questions.
Okay, we'll let you have 2.
Yes. So I'm Lindsay Russell, a gastroenterologist from Cleveland Clinic. I wouldn't prescribe loperamide. But, so I have a question for Dr. Mundi. When you're prescribing fiber, especially in someone who has bloating, do you start slowly, or do you just do 1 pack a day? What's your kind of
Yeah, no,
approach to that?
absolutely. I've learned that the typical Midwestern diet does not have a lot of fiber. So anytime we start fiber, it has to be extremely slow. And in fact, like I tend to, even in the hospital setting, go with the fiber additives instead of switching to a fiber-containing formula just to ease things in. But yeah, our typical diet may just be like meat and potatoes, and then you're going to 11, 15 grams of fiber. That can worsen symptoms, so great point.
And a question for Dr. Rice. So as a gastroenterologist, I get called all the time from ICU and say, please put this Corpac post-pyloric, put a J extension in, and I find, like as you pointed out, a lot of these patients still have vomiting or the aspiration risk is still high. Can you comment on, like, is it really worth to do post-pyloric feeding at the expense of like not feeding these patients for the weekend as they're waiting for me to do the scope?
I think a lot of the vomiting and the upper GI intolerances have nothing to do with where we're feeding the patient, right? It doesn't matter if it's gastric or slightly post-gastric or post-pyloric. The J-tube and moving it post-pyloric will work in some patients, and I think that's why we say let's try it in these patients. The one advantage that I think actually may help a lot is the gastric decompression that the post-pyloric. Now, if you put a Doboff in, we almost never have a gastric decompression in that situation. This case was set up where you could have a J-tube and then gastric decompression. But the post-pyloric enteral feeding tubes, we almost never have gastric decompression, and you're right, we still end up with a fair amount of regurgitation, aspiration, vomiting from those. I always tell the nurses, the dietitians, our house staff that if we're moving the tube post-pyloric, okay, it's not unreasonable, but don't expect that that's going to be the answer to all of our problems. Yeah, I think that's a fair point.
Now, in some ICUs, you actually can have gastric decompression and feed.
Yeah, if you want to use both nares.
Yeah, or you can get in one of those, and I can do 2 tubes in an air. I'm pretty talented that way. Next question.
Good morning. Thank you. It was a wonderful program. Had a question. I'm Diane Reed. I'm a clinical nutrition supervisor and work in the surgical ICU at Medical City in Dallas, Texas. And we've just started doing liver transplants, so we're getting a lot of liver patients. Mm-hmm. So what do we do with the patient that has high ammonium, they're on lactulose, obviously they're getting diarrhea. Mm-hmm. During that initial phase, would you feed slower until we got the ammonium level within normal range and they're having to back off on the lactulose? What would your be?
Yeah, the lactulose is, as I somewhat jokingly commented about the laxatives that all these patients are on and the diarrhea. In this situation, we're using the lactulose to try and cause a little bit of diarrhea. And I think in this situation, we would try and use fiber. We would try and do other alternatives, maybe a tincture of opium or something like that to just try and slow down the diarrhea. We don't want to stop it entirely. Right. We do, in some patients, just stop the lactulose because they have 14 bowel movements a day, which is above the threshold that we're looking for. I think you just have to try different things. I don't think there's any one answer to that situation. And as I said, it's a little bit different in that you're not trying to totally make the diarrhea go away. You're just trying to get control of it. And I think it's a multimodal approach.
Thank you.
I know that's not that helpful, but
They're tough patients, yeah.
yeah, they're hard.
Hello, I'm Cindy from Nestle Health Science in Canada. Question for Dr. Mundi, and it's actually a question about your patients that are tolerating their home enteral formulas. So we know when people are discharged, if it's not broken, we don't fix it. So if they've been discharged home on a standard without fiber, because that's what sort of worked in the hospital for them, is there a time in your patients that are being on home enteral nutrition for a while, is there a time where you standardly reassess them and say, hey, these guys aren't on formula, or aren't on any fiber. We know what fiber does for the microbiome, et cetera. Is is there a time where we reassess that when they're stable enough in the home setting, or is it just sort of, okay, we know what they're tolerating, it's not broken, we're not going to fix it, but.
Yeah, no, and I was gonna say, I looked, the real stars of our program are right here on the table, and we follow our patients at a minimum annually, and constantly are reassessing both calories as well as the choice of formula, and again, would prefer to have some fiber in there for sure, but more frequently, I think, after the hospital discharge, we try to see them back. And it depends on how things went in the hospital. So it could be like 1 or 2 weeks back, or give them a few months to come back. But we try our best to keep track of these patients and see them back. Yeah, the virtual visits have just really helped in this regard. We're working through all the logistics of licensing, and now, are even getting to the point. I had a meeting just a couple of days ago where we're going to get licenses for our dietitians in multiple states around where we are to cover about 70% of our patients, so we can again keep even tighter follow-up virtually. Yeah.
Question.
Hi, my name is Janet. I'm a dietitian from Vancouver, Canada, and kind of to piggyback on Cindy's question, in the reevaluation of the formulas, how often are you reviewing and saying, I think it's time to go from the peptide-based formula to a standard again?
Ooh,
Go back the other way.
I would not, yeah. I haven't gone back the other way. At least I could think of even once. Because again, if they're tolerating it, most of that time, the transition was either because they had malabsorption or some component of in the beginning, or they were intolerant to the formula and now they're reaching their nutritional goals. I probably couldn't think of an instance where I've gone back. So I just kind of continue on them. And at that point, insurance is covering it, so, yeah.
Now, you're
It's a
from
great-
Canada, right?
Yes.
So can I ask you a question?
Sure.
How does it work for the patients, the cost, the difference between the standard and the peptide?
Yeah, that's a great question. I mean, I'm from British Columbia, so I can speak for BC. Actually, I work with the physician who, myself and him, we review all the formula applications for the semi and elemental formulas. Our criteria is mostly to do with intestinal failure, and so if we're receiving applicants that don't meet that criteria, then we're often going back to the local teams and suggesting some other kind of workups and things like that to try before moving to these, to the semi and elementals, just because we're a provincially funded program that we do have a kind of a limited budget for that. So.
Yeah. I think with me, the way I kind of justify that, and again, the Canadian system may be different, but you saw the cost. That was per patient. And so if, let's say, one of those patients then has symptoms again and they need a workup, to me, the math, at least in the US, doesn't add up, meaning that one patient's workup cost would be more than covering formula for like 10, 20, I don't even know, more so that's the way I kind of do the math, and that's why I don't go back. And I feel like these formulas are still good nutrition, so you could keep someone on them forever if you needed it.
What's your experience when you go back? Do patients do okay, or do a large number of them recur with their intolerance?
My experience is like our program kind of grants the funding, but we're not the ones that are clinically following. However, my physician, who's a gastroenterologist, has a very close relationship with all these other physicians and teams, and we're recommending if they don't have a registered dietitian involved in their care, that to have one and to have it regular follow-ups with them. So we do find that when we aren't able to grant funding, we don't often hear back from them. So we're hoping that they have found a solution. But we do encourage people to keep applying, like if they are having issues. So I don't know. That's the cost, whether it's in one area of healthcare versus another. It's hard to see that in the whole picture. But
Yeah, for sure.
anyhow.
Yeah.
Thank you.
That's a great, I mean, it's something for us to look at, right? Yeah.
Hi, my name is Sarah, and I'm a dietitian in a rehabilitation hospital in Dubai. So I've seen lots of benefits with the changes into peptide-based formulas, and lots of my stroke patients, at some point, they transition back to oral intake. And I'm wondering if there's like any work, any research done on the patient's tolerance of actual food in the transitioning phase from peptide-based formulas to oral intake.
Yeah, that we've seen, even in our big cohort that we looked at, a number of the patients transitioned back to oral intake, and again, tolerated that well. It just, I think you just have to be careful. So certain, like, I showed that graph pretty quickly, but look at the indications. If there's pancreatic insufficiency, they've had a surgical procedure, bariatric surgery, those are the patients that when you're transitioning back, there may be, again, risk of those symptoms returning, and you just have to follow them closely. If there's normal anatomy, that transition should go okay. And it's just more follow-up, right? You just, do I follow this patient in a couple of weeks and check in, or can I go out for a few months? That's the sort of calculus you make when you're making those transitions.
You probably, Dr. Mundi, you probably don't have it, but do patients that you have on the hydrolyzed peptides transition back better than the ones that are on a non-hydrolyzed peptide?
It's a great question because we have noticed that they reach their nutritional goal, and then I would postulate that kind of leads to them doing better because they're meeting their nutritional needs and thus transitioning sooner, perhaps. But we haven't looked at that. Yeah.
And I mean, yours and some other data suggest that those peptide formulas have some positive changes in the intestinal microbiome and the microvilli and the milieu that's there. And we kind of know, and I'm not a neonatologist and a pediatrician, but we kind of know that whole area is very, very important for how people tolerate, breast milk and regular feed. So it wouldn't surprise me if they are able to transition back more seamlessly if they were tolerating the peptide-based.
It's an excellent point because the lipase cartridge group just did some work in intestinal failure patients and showed that with kind of combined peptide-based formula and that lipase cartridge, the villus length is more. It grows more and kind of is able to absorb more than in non. So I think it's an excellent point.